Hello, my name is Monak Shah, and today we are going to be discussing TB prevention in primary care. My disclosures are seen on this slide. Overall, we will be reviewing TB epidemiology and the role for TB prevention in helping us to achieve TB elimination goals. We will review and discuss the latest latent TB infection guidelines as well as reporting requirements. Globally, it is worth recognizing that tuberculosis remains one of the leading causes of death by an infectious disease worldwide. In 2019, over 10 million people fell ill with active TB disease, and nearly a quarter of the world's population is infected with tuberculosis. The incidence of tuberculosis disease is significantly higher in sub-Saharan Africa, Asia, and Europe than in the United States. That finding in epidemiology is reflected in our locally observed cases as well. Overall, the incidence of active TB disease is significantly higher in our non-US born populations in Maryland compared to our US born populations. Consequently, the majority of individuals with active TB disease that are diagnosed and treated in Maryland annually are predominantly among non-US born individuals. Nonetheless, it is extremely important to recognize that there is ongoing transmission of TB locally, and we do see tuberculosis disease in US born populations as well. In particular, it is worth knowing that in the early 2000s, there was an outbreak of tuberculosis that occurred in local homeless shelters, primarily in Baltimore City. Consequently, a single genotype was found to have spread through amongst more than 30 to 50 cases in the state of Maryland. Beginning in 2015, we found evidence that this genotype had crossed over into the general population, and cases of active tuberculosis began to emerge in young, healthy US-born populations locally, including those with no connection to homelessness. While this appeared to begin in Baltimore City, cases of active tuberculosis due to this single genotype have now been seen in other counties and surrounding jurisdictions as well. Consequently, it is worth recognizing that all cases of active TB disease do prompt a contact investigation to occur in conjunction with local health departments. Among the reasons for contact investigations is the recognition that individuals are at highest risk for progression in the first 1 to 5 years after initial infection. Consequently, testing and treating individuals for latent TB infection, particularly those with a recent infection, is critical to preventing progression to active TB disease and for our TB elimination efforts. In recognition of the ongoing transmission locally, in 2018, the Maryland Department of Health issued a clinician's memo. Within it, it acknowledged that many cases have been associated with delayed diagnoses and extensive disease at the time of diagnosis, despite repeated encounter with the healthcare system. In part, this occurred because clinicians were not aware of the local ongoing transmission in US-born populations. Consequently, we recommend that clinicians consider tuberculosis in their differential diagnoses, particularly in patients who are presenting with unresolving pneumonia or multiple episodes of pneumonia without an alternative microbiological diagnosis, or in individuals with recurrent skin soft tissue infections, abscesses, or lymphadenitis without clear alternative explanation, or even more broadly for individuals that are presenting with signs and symptoms of TB such as unexplained fevers and cough or weight loss for which an alternative diagnosis is not made. It is important to consider tuberculosis in patients, even those without traditional risk factors, such as travel or residence in non-US countries, or including in individuals that have not experienced homelessness. On the other hand, individuals with a history of homelessness do still represent a population with increased risk of exposures and should also be prioritized and considered for latent TB screening with either a tuberculin skin test or an interferon gamma release assay. Additionally, individuals with homelessness who have abnormal chest imaging or are symptomatic in any way should be evaluated for active TB disease with sputum AFB smear microscopy, culture, and GeneXpert. Now, while a consideration of tuberculosis in US-born populations is important, the majority of individuals with active TB disease that are observed in the state of Maryland are in non-US born individuals. As a representative example, I share with you a case of a 19-year-old female from Nepal who reported vomiting, weight loss, fevers, and a cough. This person had clear epidemiologic risk factors for initial TB infection and symptoms that were suggestive of TB disease, and when chest imaging was obtained, she had classic findings of a right upper lobe cavitary infiltrate, warranting evaluation for active TB. Importantly, however, and the focus of this discussion is on the prevention of such outcomes by recognizing and treating individuals earlier for latent TB infection. Latent TB infection is the seedbed of active tuberculosis disease. It is defined as a state in which the Mycobacterium has infected an individual and is viable within the body, but is in a metabolically inactive or relatively metabolically inactive or latent state, such that there is immunologic control. Individuals with latent TB infection are therefore not infectious. They typically do not have any symptoms, and often there is no radiographic abnormality that can identify the presence of latent TB infection. Consequently, if one were to try to make a microbiological diagnosis by evaluating for the presence of Mycobacterium tuberculosis in sputa or other specimens, you would find that such microbiological testing would be negative. In terms of semantics, we generally do not call individuals with latent TB infection a quote-unquote case of active TB disease. Within the natural history of tuberculosis, it is worth recognizing that after initial exposure, the organism exists in a spectrum from latent TB infection to symptomatic active TB disease. If one is able to identify individuals with latent TB infection, they can be treated to prevent the progression to active TB disease. Consequently, it is important to understand that we are not likely to achieve our TB elimination goals without improving TB prevention efforts through improved screening, testing, and treatment of latent TB. Overall, as stated previously, a quarter of the world's population is infected with latent TB. Consequently, the Centers for Disease Control and the World Health Organization have prioritized the diagnosis and treatment of latent TB in order to meet TB elimination goals of getting to cases of under 10 cases per million per year. Here I show one study that supports and provides rationale for the prioritization of latent TB. Here are the results of some mathematical modeling which evaluates various strategies on our path to TB elimination. And what is very clearly seen is that if one relies on diagnosing and treating active TB disease alone, as represented in the medium blue line in the middle, one is not likely to achieve TB elimination. On the other hand, if we are able to scale up the diagnosis and treatment of individuals with latent TB infection, we are more likely to be able to reach our goal of TB elimination by 2050. Overall, it is worth acknowledging that even though latent TB evaluation and treatment has been recommended in clinical practice guidelines, as well as in guidance by the U.S. Preventative Services Task Force, it is often not performed. In a meta-analysis of a number of clinics, it was found that there are gaps in our latent TB care cascade. Consequently, a large proportion of individuals who should be tested for latent TB never receive an initial test or diagnosis of latent TB infection. Even amongst those that are diagnosed with latent TB infection, only a handful end up starting and ultimately complete therapy. So, let us delve into each piece of this care cascade in more detail. The current guidelines outline who should be targeted and prioritized for latent TB evaluation. Here is a figure from the 2016 guidance, and what it generally suggests is that individuals who are at high risk of infection, such as those that are non-US born or have spent significant time in endemic settings, as well as individuals with high host risk of progression if infected, should be targeted for testing and eventual treatment. The focus is on targeted testing of high-risk individuals in order to improve the positive predictive value of our currently available tests and therefore achieve the highest likelihood of benefit of treatment. It is important to recognize that routine employment and other forms of testing are not currently recommended for low-risk individuals. If one was to translate this into a checklist, it would look something like this. Here I show a tool that was developed by the California Department of Health, which is a very simple checklist to facilitate the implementation of current guidelines on who should be prioritized for testing for latent tuberculosis infection. Namely, it indicates that individuals with high epidemiologic risk, such as those with birth, travel, or residence to a country with elevated TB rates for at least 1 month, should be tested for latent TB, as well as close contacts with those that have, as well as those with close contact to someone with infectious disease during their lifetime. Additionally, anyone with immunosuppression, either current or planned, should be tested for latent TB infection. This checklist gives a little bit of additional information as well, which is to say that in particular, individuals that are non-US born are preferred to have interferon gamma release assays used as the test for testing and evaluation for latent TB infection over tuberculin skin tests. This is both for operational reasons as well as for the theoretical reduced likelihood of having any cross-reactivity with BCG vaccination status. When one thinks about the diagnosis of latent TB, it is worth knowing that there are 2 sets of approved tests for diagnosis of latent TB infection, and namely the tuberculin skin test as well as interferon gamma release assays. However, I would like to point out that there is actually no reference standard for the diagnosis of latent TB. The reason for this is that during latent TB infection, the organism is in a relatively metabolically inactive state and is present viably, but within a typically within granulomas microscopically in the body. Consequently, we have no microbiological tests to ascertain the presence of latent TB infection or not. Consequently, our approach to assessing latent TB infection relies upon using indirect methods. And in particular, we evaluate for the presence of immunologic reactions after being challenged with mycobacterial antigens. The tests that are available are the interferon gamma release assays, of which there are two that are commercially available. The QuantiFERON Gold in tube has recently been replaced by the QuantiFERON Plus. And there is also the T-Spot TB test. Alternatively, tuberculin skin tests have been used historically as a way to assess for latent TB infection, and are depicted, and its implementation is depicted upon this slide. I would like to highlight that the interpretation of tuberculin skin tests is predicated on understanding a person's pre-test probability. Consequently, different thresholds are used to determine test positivity with a tuberculin skin test based on one's pre-test probability, which is based upon an individual's host risk factors or epidemiologic risks. When it comes to the interferon gamma release assays, the two sets of tests that are currently available have a number of similarities. In both tests, one makes usage of using blood, which is then stimulated with mycobacterial antigens. The blood or peripheral blood mononuclear cells are then incubated and then evaluated for the presence of an immunological reaction in the form of interferon gamma release after some period of time. I would like to point out that the performance of these tests, while good, is suboptimal. Given that there is no reference standard for latent TB infection, the sensitivity of these assays has largely been studied in individuals with active TB disease as a surrogate for TB infection. The sensitivity generally ranges between 80 and 90%. Stated somewhat differently, some individuals with active TB disease will have a negative test. Consequently, these assays should not be used as a triage test in the evaluation of a symptomatic individual with active TB disease. The specificity for these tests is also less than 100%. Consequently, there can be false positives, particularly when used in low-risk populations. Common questions that arise have to do with the interpretation of test results. Both the QuantiFERON Gold Plus test as well as the T-Spot TB test are approved for the usage in the evaluation for latent TB infection, and current guidelines do not make preference of one test over the other. When it comes to the T-Spot TB test, it makes usage of an ELISpot methodology, and the tests are reported qualitatively as positive, negative, or borderline, or alternatively as invalid or test failure. A borderline test result is analogous in some ways to having a PPD that is between 5 and 9 millimeters in a high-risk individual. Stated differently, the quantitative values are close to but do not meet the threshold for positivity. There is no clear recommendation on how to interpret borderline test results, but many experts will repeat a borderline T-Spot result after some period of time. When it comes to the QuantiFERON Plus test, the test is performed drawing blood into 4 different tubes, which are shown on this slide. One tube is the nil or negative control, another tube is the mitogen or positive control, and there are 2 tubes which are coated with antigens along their sides. The results are reported as positive, negative, or indeterminate. I highlight this on this slide just to make note that an indeterminate value is distinct and different from a borderline value on a T-spot test. In particular, an indeterminate occurs, as I will show you in a moment, when the positive control does not have interpretable results. While the QuantiFERON Plus does not have a borderline category, it is worth noting that quantitative results are typically reported as well, and it is worth further evaluation when the quantitative values are near the cut point. And in particular, in low-risk populations, individuals with results that are near the cut point can lead to discordance on repeat testing. Here I show the details of how the QuantiFERON Plus test is interpreted according to the package insert. And in particular, I want to highlight that an indeterminate is a test result which cannot be interpreted because these are situations in which the positive control does not have a detectable value. A common reason this could occur is because of inappropriate handling of the test. For example, given that the antigens are pre-coded on these tests, if an insufficient amount of blood is drawn or there is not sufficient shaking of the tubes, the blood will never come in contact with the antigens and lead to failure of the positive control. On the other hand, individuals with severe immunosuppression may also have an indeterminate result as a result of not having sufficient lymphocytes either present or functional to mount immunologic reactions. A common question that occurs is related to how the interpretation of discordant tests when two or more tests happen to have been performed. Given that there is no reference standard for the diagnosis of latent TB, it is impossible to know which test to rely upon when you have more than one test that has been performed with discordant results. In clinical studies, there can be up to 20% discordance between different tests, and this can occur in all different permutations. For example, one can have TST positivity with negative IgG results, or vice versa. One can also see positive QuantiFERONs and negative T-spots, and vice versa. Overall, the general intuition is to assess the pre-test probability when interpreting these test results, and in particular when interpreting multiple test results. In low-risk populations, negative tests are more likely to represent the truth, whereas in a higher risk population, the positive test in a discordant pair is more likely to represent the true state of presence or absence of infection. Maybe stated a little bit differently in pulling from the current guidelines, there is acknowledgement that dual testing may be considered in several different circumstances. For example, in an individual that is immunosuppressed and has had close exposure to a highly infectious case, one may consider dual testing, and given that no single test has perfect sensitivity, one could consider any test that is positive to represent a positive result. On the other hand, there is also acknowledgement that in very low-risk populations, such as US-born individuals with no exposures, one may consider repeating or dual testing in which a negative result is the one would consider to be the most likely to represent the truth. Consequently, this also echoes the overall guidance that one should focus on targeted testing and avoid introduction of testing in low-risk populations. Now, I'd like to shift gears and spend the remainder of the time to talk about how to evaluate and manage an individual who has a positive test for TB infection, whether that test is a tuberculin skin test or an interferon gamma release assay. The first step is to acknowledge and recognize that a positive quantiferon T-spot or tuberculin skin test does not differentiate between latent and active TB disease. It is simply an immunological assessment that an individual has likely been exposed and infected at some point in time with the Mycobacterium tuberculosis bacterium, but does not tell us where a person is in the natural history of the disease. Consequently, before making a diagnosis of latent TB, one must actually assess for and evaluate and exclude active TB disease. This is done through usage of a symptom screen, as well as imaging, such as a chest X-ray. These elements attempt to identify the presence of replicating bacteria causing a subclinical or clinical presentation. It is important not to start latent TB therapy until the evaluation for active TB has been completed. If a person is symptomatic or has abnormal chest imaging, one would then proceed to evaluate for active TB more formally through microbiological testing. Here I present a schematic of the approach to interpreting and managing latent TB test results. If a tuberculin skin test or an IGRA is positive, as I just mentioned, one would next conduct a symptom screen and conduct chest imaging. If all of that is negative, then we typically would call that a diagnosis of latent TB infection and proceed to treatment. On the other hand, if there is abnormalities in the form of having symptoms or abnormal chest imaging, one must proceed to the appropriate set of testing to evaluate for active TB disease. So for example, if there is an abnormality on chest X-ray, one would collect sputum to determine the presence of actively replicating mycobacteria. Once active TB is excluded through negative testing, one could then proceed with a diagnosis and treatment of latent TB. In the instance when you have an indeterminate or a quantiferon or an invalid T-spot, one could consider repeat testing. Alternatively, if you have borderline quantitative values on the T-spot or even on the quantiferon, one could consider repeating the test at some future interval. And if the test is negative, in general, this excludes latent TB infection to the extent that these tests are able to do so, recognizing that their sensitivity is imperfect. In general, there are not recommendations for repeat or serial testing or screening, but this is a case-by-case scenario based on exposures. For example, in the context of a recent exposure, local health departments are likely to assess for latent TB at multiple intervals, given that these tests may not convert to positivity in the very recent period after initial infection. After a diagnosis of latent TB is made, it is important to proceed to treatment because treatment prevents progression to active TB disease. In most clinical studies, the usage of latent TB therapy reduces the incidence of active TB by 60 to 90%. Recently, the guidelines for the treatment of latent TB infection have been updated. In particular, rifamycin-based quote-unquote short course regimens are now preferred for the treatment of latent TB. The historical regimen of isoniazid or INH used for 6 to 9 months is now an alternative regimen to be used primarily in instances when a rifamycin such as rifampin or rifapentine cannot be used. There are 3 current short course regimens that are typically used and recommended by current guidelines. The first of these is 4 months of rifampin, and here I show just one of the trials that underpins its usage. In a large randomized controlled trial, the usage of 4 months of rifampin was non-inferior to using 9 months of isoniazid. There was also higher completion rates and reductions in adverse events. Consequently, 4 months of rifampin is a preferred regimen in the current guidelines for the treatment of latent TB infection over 9 months of isoniazid. Similarly, the shortest regimen that is currently recommended is 3 months of weekly isoniazid plus rifapentine. Isoniazid is abbreviated with an H on this slide and rifapentine with a P. Notably, this is a weekly regimen, and what one sees on this slide are the results of a multinational randomized controlled trial, which showed that not only was 3-HP non-inferior to isoniazid, the curves really separated, suggesting that 3-HP is likely to be more effective than 9 months of isoniazid in the prevention of active TB disease. 3-HP was also better tolerated with fewer side effects. Consequently, 3-HP has been incorporated into the guidelines since 2011. In more recent guidelines, the populations for whom this regimen has been recommended has been expanded and includes individuals as young as 2 years old, as well as individuals with HIV infection. While prior iterations of guidelines have suggested that this regimen should be given with directly observed therapy, I want to note that the most recent guidelines indicate that this regimen can be administered under self-administration as well. The latest regimen to be introduced into the 2020 guidelines is a regimen consisting of 3 months of daily isoniazid and rifampin. This is abbreviated as 3HR on this slide. Here I show just one meta-analysis which includes 5 separate studies providing data on the effectiveness of 3 months of isoniazid and rifampin. And all told, the adherence was equal or better in all of those individuals getting 3HR compared to longer courses of isoniazid, with similar rates of hepatotoxicity and improved or similar effectiveness to 9 months of isoniazid. I would like to just introduce the audience also to the fact that there are newer regimens that are coming in the pipeline. Most recently, a regimen studying 1 month of daily isoniazid and rifapentine was evaluated in a randomized controlled trial in people with HIV and found to be non-inferior to 9 months of isoniazid. This regimen has not yet made it into current guidelines, but the authors did conclude that 1 HP, or 1 month of isoniazid and rifapentine, was effective and safe in preventing TB disease. Some of the reasons why it has not been incorporated into current guidelines is that this study was done primarily in high incidence settings, and overall, the number of individuals included who had baseline testing for latent TB infection was relatively low, and consequently, the risk of progression to TB disease was relatively low in this study. Additional trials are underway. Overall, it is worth considering that when using rifamycins, there can be a substantial number of drug interactions. Common drug interactions include usage of anticoagulants such as Coumadin and hormonal contraception. Many, if not most, antiretroviral treatments for HIV infection also can interact with rifampin or rifapentine. Tools such as HIV Assist listed on this slide can be useful in helping to assess those drug interactions. When using rifamycins, patients should be warned that there can be red to orange discoloration of urine, saliva, and tears. One may also need to consider more frequent liver function test monitoring among individuals at risk for liver disease, including those with non-alcoholic fatty liver disease, viral hepatitis, HIV, and in some cases pregnancy as well. Typically, these regimens are extremely well tolerated, and we only generally stop them when liver function tests or transaminases exceed 3 times the upper limit of normal in the presence of symptoms or 5 times the upper limit of normal in asymptomatic individuals. For very high-risk groups, one may consider usage of incentives and enablers or case management to ensure completion of preventative therapy. Overall, latent TB has become a reportable condition in the state of Maryland since 2018. For reporting purposes, latent TB infection is defined as a positive result on an interferon gamma release assay, tuberculin skin test, or any other test indicating TB infection. A diagnosis of latent TB is made when active or suspected TB has been ruled out. While implementation continues to evolve for the reporting requirements, I will note that the forms are available for latent TB reporting by following the link on this slide. The diagnosing provider is currently responsible for reporting, and the reporting forms can be faxed directly to the Maryland Department of Health. If you fax to your local health department, such as the Baltimore City Health Department, the local health department can forward this onward. There is electronic lab reporting that is active for some labs, and it is worth knowing that the reporting requirements includes not only the reporting of latent TB evaluation, but also outcome details, including whether or not treatment was initiated and completed. Overall, I'd like to conclude by stating that latent TB diagnosis and treatment is critical to TB elimination goals. Individuals at the highest epidemiologic risk or at high host risk for progression are the ones recommended for targeted testing of latent TB infection. IGRA tests are preferred in most situations over tuberculin skin tests for the diagnosis of latent TB infection in the most recent guidelines. But interpreting all tests does require an assessment of pre-test probability. Short course rifamycin therapies are now preferred over longer course isoniazid therapy, and such regimens are better tolerated as or more effective as isoniazid and are more likely to be completed. A number of additional resources are indicated and listed upon this slide. Please note that if you have questions about latent TB infection or active TB disease, one can always call the Center for TB Control and Prevention at the Maryland Department of Health or your local health department for additional guidance or clinical consultation. Thank you for participating in this educational event.